All right. Thanks, Howard. I'll be brief. Here's what it is that we're trying to work on. As SG Innovate, which was announced by Minister Heng last year, we're trying to work together with the venture capital community, with technologists, with companies of different sizes, to build important things from Singapore for the world. So our goal is not to build for Singapore, it's to build from Singapore for the world and for Singapore to benefit. So our goal is, because Singapore has, like many countries around the world, an aging population, that creates a lot of pressure on the healthcare ecosystem. If you're watching at all what's happening in the UK right now, there is a crisis, using the words that are on the news, because patients are in corridors for 8, 10, 12 hours before they're being attended to. That's because the overload between patients that need care and the number of providers that can provide care. And so we face a different dynamic in Singapore, but the aging population tripling over the next 12, 13 years is inevitable. And the reality is that the things that afflict an older citizen in terms of chronic conditions continue to stack up. So the longer you live, the more things you need to deal with medically. And part of what we're trying to explore is, how do we think of robotics as assistive, not something which is replacing. It's not our goal to replace people, it's our goal to assist. So the goal here is, what can we do? What can you do? And our goal as SG Innovate is simple. We've got some amazing men and women with whom we work. You're in our space today. We've got Minister Vivian Balakrishnan, who, for those that don't know, is also an eye surgeon, an eye doctor. He'll be with us for the main event because he wants to spend time personally engaged in this, so we hope you'll remain involved. And our goal is, from this, we fund and build products and companies. So this isn't something where we want to hang out and see what cool ideas we can have for a couple of days. It's go on and build something that goes on to be a positive contributor to Singapore, but also other countries. So that's it in a nutshell. Thanks for joining us. Look forward to working with you both now and as we go forward. And let's see if we can build something from Singapore for the world. Thanks.
Hi, thank you. We have a very exciting panel today with people with diverse experiences. A couple startups that we have here today who have started their own companies around healthcare for aging. And also we have IHIS, and we also have robotics. So first, I'd like to welcome Selena Sia. She's the Assistant CEO and the Director of CHART, which is the Center for Healthcare Assistive and Robotics Technology at Changi General Hospital. Come have a seat. And we have Edmund Wan, who is the President of the Handicap Welfare Association. And Gerard Chu is the head of IHIS Innovation Labs. And for our startups today, we have Calvin Cheng, who's the founder of the Caregiver app, and Jason Feng, who's the co-founder of Maxerence. Both of these came out of the last MIT Hacking Medicine event in Singapore in July 2015. And then we also have Dr. Artik Sarma, who's going to be joining us, technology willing. He's going to be calling in. He is a resident of internal medicine at Massachusetts General Hospital, and he's the founder of SCPAP. So the purpose of our panel today is to really understand what are more of the pressing needs when it comes to aging that social robots may be able to assist with. And so you can really start to identify and think about what are the opportunities that you'll have in February when you're hacking the Segway robot, some of the areas to think about. As we know from reading the news and from conversations that we have on a regular basis, that the rising cost of caring for the elderly is not new to us in Singapore. Technology is often mooted as the answer, both for better efficiency and also to improve care. In particular, robots have the potential in this space, from companion robots for dementia to security guards at nursing homes. However, technology in healthcare cannot be for the sake of innovation alone. And we always have to keep the patient or the citizen at the center of any healthcare solutions that we develop. Our objective with this panel is to share our panelists' views on the elderly's experience with technology and robots, and to, again, address the most pressing needs when it comes to elder care. So starting with, one question is, we know there are a lot of opportunities for elderly patients and their families to interact with IT and with technology in healthcare. And whether it's sometimes a simple app to be able to check your medical records, to interacting with a robot in the hospital hallway. We know we've seen some robots that are being used in some of our hospitals, or using a more advanced rehab tool. In your experience, how have the elderly and their families responded to these increasing levels of technology in their medical care?
All right. Okay, I'll just provide some very general comments first. So, first of all, there isn't one set of elderly that would have a prescribed set of responses. We have a very diverse mix of elderly, from those who are technologically savvy to those who are actually more averse to technology. So essentially, you need to look at different cohorts in order to be able to contextualize your solutions. Technology, there's no one-size-fits-all for everybody, right? So I think with that comment, I'll pass it on to my other panelists.
Hi, my name is Selena. Well, it's a pretty big question, and what we could share with you perhaps are some of our current experiences with some of the current projects we are doing, and perhaps that will give you some insights on what are the takeaways. As Gerard says, there's no one set of elderly, and every individual is different. So just 3 tips. One, looking at one of the biggest country around us that has been very interesting to study, because they have a very traditional culture and yet a very modern take-up in their living, and that's Japan. And looking at that country and how they have been handling the fastest aging population in the world, we had a couple of insights from them. And when we incorporate some of the trials here in Singapore, it's found to be quite similar in terms of takeaway. So one interesting project that they did was to see how they can connect the elderly together. And we're just talking about well elderly, and we're just talking about connection here. No robotics yet. And in that sense, what made it very interesting was that whilst the younger generation is quite happy to interact with apps without the need to talk, that's not the case for the generation before us. So whilst IBM, Apple, and the Japan Post came together for a pilot for over 1,000 elderly folks in Japan, what was found that the iPad had worked well even for a 2-year-old kid playing in a restaurant while the parents are eating their meal. It doesn't work for the elderly. They need to talk to the iPad. That's their culture. So you must remember that there was a time where we pick up the phone and speak to one another. We don't email. There was a time when we actually have to go out of the doors and say hello to your neighbors. We don't WhatsApp. So that has not as yet changed. Do we want it to change? We don't know. But we are talking about the elderly today. Maybe when we become elderly, which is pretty soon for me, it might be okay as this becomes our culture. But the elderly today need to communicate traditionally. So hence, whilst we may have technology that works, it's not a technology issue. It's how do you get people to age in the culture and setting that they are comfortable in. So if the elderly needs to speak to the iPad instead of pressing the apps, then that's something that we need to consider. So that's tip 1. Tip 2, when we age, our eyesight and ears and joints go first, unfortunately, before the heart. So which means we live longer, but we have to live increasingly in less functional ability. So hence, in order to work a technology, it must be something that it's only one button, big button, no instructions required. If you need to bring someone in to train for that piece of technology, most of the other pilots are now looking at creating centers where we can congregate people so you can centralize your training. If you need to deploy something that requires a book of instructions, think through, because the take-up will be very bad. Okay, and unfortunately, to send manpower out to individual homes is going to be very costly also. So that's tip number 2. Tip number 3, with regards to supporting the technology right now, the big overlap for us is actually where hardware meets software. There's a lot of brain power locked up in IoT. There's a lot of technical engineering power locked up in what you see that's scintillating in front of me. But how do we actually do this very effectively so that it is easy to deploy and it captures the brain power that is available in the analytics world, in the AI world, without having to land a shuttle space in Mars, because that's where it is all used right now. But you're talking about an elderly person at home. You're talking about an elderly person in the community. How can we make it easy for them to get the right information at the right time, at the right place, so that it enables them, empowers them to do what they need, to stay connected in the community? So that's my 3 tips from the pilots that we've been working on. And with that, perhaps I pass to anyone else wants to make a comment.
Ed, do you have any insights on this?
Okay, my name is Edmund Wan. I work with people with disabilities. I'm not a robotic expert, but I do understand quite a lot of people with disabilities, the feeling. Much to say, I myself is also, I had polio when I was a baby. Now, the thing, what she says, Serena says, is very true. And I agree that robotics has not been into the field of rehabilitation for the elderly. It's not something which they can accept because their generation is not technology savvy. All they want, sometimes we often overdo and produce something much more than they needed. All they want is simple thing. Get out, wake up, walk around, eat, sleep. And that's the basic, simple philosophy they want. In fact, to me, when I look back in all the disabilities, it is because they don't exercise, they don't take care of themselves. That's why they landed up in many of these. So I would not think that solving robotics for this elderly, we should also have some sort of preventive medicine. Have them young and become more agile, not till then when they are old. Technology is good. Robotics, I think I've seen quite a number of them, and I think it's very positive to me. It helps. In fact, it is an assistant to the therapist, but it will never be replaced the therapist, let me tell you honestly. Because as you have heard, a person with disability has many types of pains and different, no one disabled person has the same pattern of pain. And that is important. So that is why it is very challenging how to capture all these things that they wanted to say. Now, I actually had a little diverse when I came and as I was taking a bus and think, while elderly is one area of robotics, it shouldn't stop. I mean, I'm not saying that it is good. I will actually venture to say that I look into a field of what you call early intervention, children with disabilities. I think this is one potential where you see results, quick results, and ultimately, hopefully, they can be by themselves. Because elderly, most of them, if I'm not sure you've heard, I deal with the elderly, they hear them say, oh, I'm old already, what's the point? I only got 2 years, 3 years, 4 more years to live. Do I really need all this? Do I all this? I think that is the number of a block. It's the number one block that, not because of technology savvy, but they say, even sometimes doctor says, no point operation. It's too old already, you know. Let him enjoy. And I think that the beauty is let him enjoy whatever he wants to. And that answers the question of why you develop things that you must develop things that he enjoys doing, not what you tell him what to do. And that actually brings me back of one lesson that I learned from the rehab manager. They actually try to make a person walk with their leg, walk the parallel bar. But you forgot one thing. He walks with the teardrops. Every walk he got a teardrop. Why? Because his leg ankle there is not it's giving him pain. So we don't address his leg first. Then you try to make him walk. So we tell, walk, I think it's good for you. You can learn how to walk. But you walk with teardrops. And after studying the case, we created what we call the ankle foot orthosis. And he can walk. And actually has great, tremendous improvement. So I would like to let others to have a say. But I just want to say that I'm more from the down-to-earth things.
I think you both brought up a couple really good points of, a lot of times we talk about right-siting of healthcare, but also the potential to right-site information. What use is it to get information, but you don't recall it at the time that you actually need it? How can social robots potentially play a role in right-siting information? And like you're saying as well, about a focus on prevention. And when we talk about aging, that it's not just talking about someone who has a disability and how a social robot helps them at that point, but even a younger person, especially with the focus of the government on active aging. How can information early on, so that right setting of information, contribute to active aging later on in life? And your example of disabilities, a personal example from my family, and this is the right setting of information, is my mother had a learning disability at a young age. And at that point, they didn't do anything about it. They just diagnosed it and said, good luck. Welcome to bad grades the rest of your life, through school, because they didn't have those tools. So, and that affects adulthood as well, as far as how that a person approaches learning, how that person approaches, written communication. So being able to give the appropriate information at the right time, even early on, can affect that person's older adulthood. And also, you also bring up another very interesting point as well about, at what point are we bringing in social robots? Is another question that we had was, a local news channel recently aired a documentary that questions whether we are helping the elderly into helplessness. So sometimes, if we give too much help, are we reducing their choices and making them feel disempowered and disengaged? Do we want to do everything for someone? Or in your experience, how should we take the approach of giving elderly and their families the right level and type of help, but where we're also encouraging them to do as much as they can on their own?
Hello. Hi. So just a bit of background. Caregiver app was created as part of MIT HackMed, the previous MIT HackMed. I was part of the team that won first prize. I was working with a dementia consultant and a robotics guy, and we were all strangers when we met during the event, and we created this checklist for caregivers to monitor the health of a care recipient, elder or not. So in relation to that, tools like this, right, whether it's a caregiver app or a very, very interesting one that I recently came across called Groovy. Groovy is a music-making app. It's a toy, you can call it a toy, but they encase a normal smartphone to play erhu, a traditional music instrument, and all kinds of traditional music instruments, and they pass this tool to community centers where the elderly, the seniors congregate, and they could compose music using the tool. So Groovy to me is one of the outstanding example to empowering seniors instead of coddling them. When you give them the right tools and user-friendly tools, as mentioned by Edmund earlier on, you could see very interesting behavior from your users. And I think that's one of the key roles of technologists. We are not there simply to think of creating products simply for technology's sake, but to create products that empower the end user to allow them to do things that enhance their experience. So that's an excellent example of augmenting elder experiences.
Yeah, my name is Jason and I'm from Experience. So a bit of background on our company and what I'm doing right now. So we are developing a medication adherence device for the elderly called Pilpresso. So essentially what we are trying to solve here is the problem of medication adherence within the elderly population. Diving into the question now. So essentially what are we trying to solve for the elderly, and whether or not they will perceive our product as something that they would use and help them in their lifestyle. So I do echo the views of my fellow panelists here, meaning to say that how acceptable are they to technology? Framing the question around what is their current behaviors and their cultural settings that enable them to accept new technology. I don't think it's so much so as a generalization to say that all elderly people are technological adverse, but it's rather how you develop a technology that keenly reflects their behavior, their lifestyles, that enables certain things like, first and foremost, aging in place. Okay, so giving you an example on how we attempt to introduce technologies into people's life. It's actually keenly understanding the patient journey as well as the caregiver journey profile. And at every point of their journey, you consider what has to be done and what are their goals to achieve those things. So from that standpoint, they have a goal to achieve. They might have a barrier to overcome them. So that's where you can possibly see assistive devices and new technology coming in to assist them in their achieving their goals. So from that standpoint, you also want to consider the care support that the patient is actually receiving, be it their caregivers and their doctors and the healthcare ecosystem surrounding them. So a lot of times what we do observe is when the patient actually gets discharged from the hospital, there is a break into the continuum of care. So a lot of the times you receive a lot of instructions from doctors, the pharmacists, your nurses on how to manage your chronic condition. And then when they go home, they got so confused about how to actually go about managing their disease that sometimes, most of the times, they just simply give up and find that, yeah, I really need help. Yeah.
So as we, oh, sorry, go ahead.
I thought maybe I would try and round out some of this, otherwise it gets a bit too much to carry away, because healthcare is one of those domains. You speak to 10 people, you get 10 different opinions. But coming from some of the things that we are trying to do, as much as we say that every elderly is different, we're broadly trying to classify our strategies into 3 groups so that it allows us to think about what are the needs within those 3 groups. The first being the group that we would like them to age well. So they are fine, they can, even if they have chronic diseases, even if they have slight disabilities, we just need to help them to age well. Now in that category, connectivity and the ability to be part of the community is right at the top of the list. The second group is to get well. So to get well group are those who we need to put in assistive technology to help them to get back to a better state of health or wellness. So the get well group is where a lot of effort is being put in today with regards to assistive technology and how to get the caregivers burden lowered and so on and so forth. The third group, it's called stay well. So you have gone through the journey as described, would allow you to come to a certain state of health, may not be optimal, may not be pre-morbid, as we said, before you got sick, but it's optimal to where we can, what medicine and your own individual motivation can get you to. Now, the stay well is actually an area that we will require to think through in terms of human motivation. What actually motivates someone to stay well? This is in line with what Edmund is trying to say earlier. So just 3 big areas to think about because they require different approaches, philosophies, and even business models. But I thought I'll just round out in that.
That's very helpful, thank you. And that's a very good way to think about primary prevention and secondary. And also another thing, so at the event in February, when we're just giving information on particular pain points around aging, we're also going to be looking at place-based, so different environments where older people are. So whether that's the home, the community, a nursing home, where we're looking at different environments where a social robot could be of use. And that's a good way to think about within each of those environments, how do you look at prevention for different populations and also help them to maintain wellness. So another question around adoption of healthcare technologies. What is your experience on adoption from the health provider side? So we know that sometimes there'll be a technology that comes in and people get really excited about it and they go for it right away. But then there's other times, and it could also be who you're talking to within a healthcare organization. A high-level person who says, this is exciting and cool, I want us to do it. And then the nurse who goes, you just added something else to my day. And that's really, that's going to be the key part of if something works or not. Is the nurse willing to use it? Is the physio willing to use it? And being able to get adoption at that level. So what have your experiences been in adoption by the healthcare organizations?
Okay, this is the most exciting question for me, really. Because whilst she's very correct, while we can come out with the best and most ideal product, often getting it as part of the clinical protocol is the trick. So you're right, can be somebody very high level or an organization which is placed or appointed to buy products for people, for healthcare providers. Everyone can get really excited. But to get it in place into a clinical protocol, it's where we want to center most of our current piece of work, at least in chart. Now, it is important that we need to see that technology adoption comes in, it comes in 3 circles. Okay, technology adoption is only one. The other 2 pieces are just as important. How is this going to change the process that every healthcare professional has been trained to do, licensed to do, licensed to practice? And to a certain extent, technology adoption by the medical profession is a very established process, okay, which means there is device certification, the doctors go through tremendous amount of training, certification before they take it up. But all this is charged back to the patients, right? And the fee for service. So, but when we talk about nursing, caregivers, physios, often their services are not exactly fee for service. Now, in that ambit, if we were to say, let's change practice, which does not allow their regulatory body to understand how it works, it does not put in place job redesign for them, then theoretically you're right. It's an adoption that will just be left in a storage room. Okay, so as such, it is actually a far more difficult piece than medical device. Medical device, the regulatory process is arduous. 7 to 10 years to get your medical device licensed by, say, FDA. Okay, so that by itself has got a lot of gateways and checks, and also a lot of time for the medical professionals to come in and give inputs. For the non-medical devices that we are talking about, let's say assistive technology, now those regulatory processes are not as long. However, we will be hit by the need to change the way the professionals work. And that is something that we need to actively look in. So hence, the encouragement is, while coming out with the products, actively speak to the group that you are targeting the use for. Now, if the product is going to be used by non-healthcare professionals, i.e. Your caregivers, your elderly in the community, that's fine. It's like, you know, a wellness product. But if you are going to look at getting nurses, therapists to adopt the technology, then their inputs on how that process is going to be changed needs to be upfront, really upfront. And if you need doors open in that, please feel free to approach us. We'll see how we can help to get you to talk to the right people.
Thank you for that offer. I also want to, Dr. Sarma, are you on the phone?
I am. Can you hear me?
Yes, we can hear you. Excellent. So I'm sure you have experience on this from both sides, being both a founder and also a medical resident as well. What have your experiences been with adoption of technologies from the medical side and willingness to adopt and change processes for this?
Sure. Sorry. Unfortunately, I didn't hear the last panelist's answer, so forgive me if I repeat something that they said. But I think my incentives as a clinician are a couple. One is, as I'm sure is the case, in most clinical settings, I have a lot of patients to see, and I want to make sure that whatever I'm doing uses my time efficiently. But the introduction of a new technology usually often means that I have to learn a new process or I have to learn how to use a new software. So if it is designed in such a way that it's frustrating, then it probably is going to lead to a lower likelihood of uptake. And this is true of any market, but I think it's particularly true of physicians and nurses who have processes that they think work and work well. So unless you specifically are addressing the pain point both on the provider side and the patient side, you might not see the sort of uptake you want. And another incentive I have, though, is I want to see my patients get better. So if you can show me a clear benefit to the intervention that you are introducing, then I might be willing to spend the extra time. So if you can show me, for example, that my patient is walking more, or that they are having more hours of the day pain-free, or whatever your goal is, if you can provide me that sort of useful feedback, that provides a lot of the satisfaction from my job that I hope for. So I think it's just as important to think about the provider's user experience as it is the patient's user experience, mostly because while the patient is the person who may be paying for something, providers are often the people who are going to be referring patients to your services.
Thank you for that. And I know I've been the one asking the questions for the first half of this. I want to open the floor to any questions that people may have. You guys are a quiet bunch this morning. Have people not had coffee yet? Okay, we'll take care of that. But first, all right, we'll get some questions going. Any questions? Yes.
Okay, so my question is, if all of us, like students, like employees, people working, government, people in the medical field, if everyone wants, say, new medical devices and assistive technology, why does it take so long for regulations to go through? And like, can we do anything about it?
I'm gonna let the Selena and Gerard answer this. Gerard.
I think that's a very good question, actually. So I forgot to introduce myself. I'm Gerard, of course. IHIS is our integrated health information systems. We look after the IT systems for the public healthcare sector in Singapore. So I think it's an interesting question. And there are, of course, different categories of devices that we have classified these into. And each of these have their own approval and regulatory processes for very good reason, obviously, right? There's invasive devices. You don't want to start sticking things into people without having this thing being approved. But there are also those that potentially don't have any of these impacts as well. And so this is why I just wanted to sort of help you characterize what Selena has said and maybe give you 3 areas that you can look into where the onus of proof of use is not as high on yourselves, right? Specifically, there are 3 cohorts that we typically classify our target population. We have those who are well, those who are at risk, and those who are chronically sick. So obviously, for those who are well, the question is, how do you keep them well? And I'll give you examples of what we're doing. We've got, for example, within our ministry, we've got population enablement programs. So these are education programs, the Keep Fit programs, the Keep Active programs, exercise programs, Eat Well programs. These may not have as high a burden of responsibility on yourself for targeting this cohort. Then, of course, you have those who are at risk. Now, for good reason also, the at-risk cohort does require a level of clinical awareness. Be sure that you know what you're doing when you're advising someone. It could be fairly simple if you were to look at, for example, representing a different form of a scoring system. For example, we use something called risk scores index. Many doctors and clinicians do that. Present it in a form that is less intimidating to your elderly, for example. Have a robot talk to them that way. Assess their feedback based on their responses, but do it in a way that you're framing it within the context of a formalized scoring system without making it apparent to your user, right? Then, of course, we've got those who are already chronically sick. Then that's where really your burden of responsibility is much higher. Your clinical burden is much, much higher on that. And I'm sure you can appreciate there's good reason there as well. All right.
So you are a programmer or something, software guy. I completely understand where your question is coming from. If you compare the span of different kinds of product across the spectrum, there are products that are not life and death. So the only limitation is how fast you code. Nobody cares if your server goes down for 5 minutes. You know, you can get it up again. If you are building an Instagram or Facebook, nobody dies if the Facebook goes off for 15 minutes. Maybe people will, but you get my point. And if you build more sophisticated products, one of the first products I built throughout my career, over 10 years, I'm a generalist engineer. I build software and hardware. Was a deep freezer. That deep freezer cost about $10,000 per piece, up to $20,000. That deep freezer is not the same as your consumer fridge. Your consumer fridge is, what, $2,000, $3,000 for an expensive branded one. The kind of deep freezers that we built cost $10,000 to $20,000. It's sold to hospitals. It's used to store blood samples. It's used to store years and years of research work. If your freezer conks out, you're in trouble. You are looking at $1 million worth of losses straight away. Important biological samples being lost. So across the spectrum of different products, there are different risks at stake. So the approval process is there to, for lack of a better word, cover ass. Even our freezer required 2 to 3 years of underwriters' laboratories approval in order to get it to market. And that was just a freezer that doesn't involve putting something into a person's body. So where you choose to, what problem you choose to target, what solution you choose to deliver, they have different product cycle, so to speak.
Other questions?
So my question is to Selena and Edmund for that. So if I understand, at a high level, we discussed that mobility, emotionally, communication, and preventive is the area that the aging population actually feels, right? So from both of your experience, what is the main thing that we can help the aging population to be? Is it more of a communication? Because I think that when people age, they really want to talk to someone also, right? So is an emotional aspect higher, or just helping them to age well with a preventive measure of the medicine or anything is higher? Which one is higher, emotional aspect or the medicine?
You're asking healthcare where we look at things holistically? Yep. Okay, so the point is that where we often look at is how can this improve or bring value to you, right? So as Dr. Sharma was talking about, from the healthcare part of the world, because we are looking at payment, we are looking at insurance risk, so any innovation that comes in, as rightly pointed out, we need to see the value it brings to the patient. So that's the component to say that, okay, if we are looking at connecting elderly, preventing them from, looking at preventive medicine, then what is that value that the technology can bring in? Just technology value, filling that function. Now, then while that can be solved, the second piece that overlays it is how would the user, be it the patient, inverted commas, the targeted user, or the provider is going to use it. So your question, you need to split it into two. So you need to be very clear what is the value proposition first. Then when we are looking at the healthcare space and looking at elderly, then you need to understand the psychology of if you had been an extremely active, useful individual in the community, then you retire. Then you start finding that you are getting, eyesight is failing, ears is failing, you don't feel as useful. Where that isolation and loneliness becomes higher on the list than someone who is not. I'm not saying all elderly people are like that, I'm just saying there is a possibility. So as such, when we want to get the product to emotionally connect with someone who's using it so that they find that it's an easy piece, something that they will not run out of the house without, that connection is what we are talking about. So you need to then allow them to interact with your technology. And the elderly people, it's not about apps and stuff like that. It's about the ability for them to connect in the traditional way. That's sort of separating the two discussions.
If I may add from the ground level, most elderly accept their disabilities or shortfall. They do not, want to expect to say, for example, if you have a motorcycle accident, and or elderly, an elderly who to have another hand, a bionic hand, they don't ask. Let me honestly tell you, they don't ask. They just accept it and live with it and adapt to the way of this handicap. In fact, most of my handicapped people say, I'm a handicapped, so there's nothing to fear, nothing to be worried. God made us this way, so be it. So in this type of area, which an earlier question was raised, where is the really acceptance of this robotic technology to go? I think it starts with hospital is the highest, because old people they always say, doctor says this, doctor say this, doctor say I must have this, doctor say I must have that. It's just that when you're in school, the teacher say this, mom, teacher say this, not you say this. That is the first level. The second level is actually, our welfare organization, the community. And the last, actually, nursing home is like a sunset years. They take it as a sunset years for them, and they really don't ask for any more because it's just waiting for time. So I think the higher level, the most target high level is hospital. Hospital is the best way to introduce this to them. Otherwise, they just accept as it is.
If I may add, so coming from an engineer's perspective, you always want to identify and define what is your problem that you're trying to solve. So I would like to rephrase the question that you asked as, what am I trying to solve in the first place? So identifying what to solve is the key step that you need to take. Then subsequently, you try to see what technologies are out there, or innovate by yourself. And then the engagement part, as well as the adoption of your technology, as well as the acceptance towards your product, that comes after. So essentially, coming back to the basics, what is the problem that you're trying to solve is something that you have to identify as key first before actually considering whether or not you should input emotional, communicative aspects of interaction with your potential buyer or user. Yeah.
I think, which is one thing I would add there, you know, most of my work as a physician obviously is in treating physical ailments, but at the end of the day, my goal in treating those ailments is to allow someone to enjoy their life more, right? If it's not so much that someone's poor eyesight is inherently bad, it's that it inhibits their ability to engage in the community, to have the roles that they had in the past. So, particularly as we get older, we, as physicians, often reassess if someone should be on all the medications that we had them on when they were younger. So, say there's a marginal gain of, you know, taking 20 pills, and it may lower your risk of suffering a minor condition 10 years in the future. That may not be a relevant consideration when you're 95 years old. So we try to balance, you know, our interventions with ultimately the goal of trying to get someone to enjoy their health and their life. It's the ailment itself is not necessarily what we're trying to treat. And along those lines, also an engineer by training, and thinking in terms of the parameters that you're designing for, I think particularly in healthcare, it's important to think early about the product and to think early about the user experience, and then think about what technologies you have available. So let's say when you're identifying the problem, to really think about that experience before you try building the entire technology and then layering a experience on top of it, but to really integrate those two development processes at the same time.
And I would like to add one challenge between now and February 10th for everyone who's in this room is a lot of times when we talk about the pain points and older people's, we take a very academic approach. We're going to be providing materials in February for the hackathon. We're going to be talking about what are some of the specific needs. But the challenge between now and then is to buy one older person a cup of coffee. I'm serious. I'm serious. We Access Health, we do the Modern Aging Program. We talk to a lot of entrepreneurs who are trying to solve these solutions. And I still, on my way home, I get off the MRT, and at 6 o'clock, there are 4 or 5 elderly people who are at the playground, and they're just sitting there in their wheelchairs. And their helpers are right next to them, but they don't speak the same language, and they're on the phone, or they're chatting, and people are just sitting there. And or people in my building who I only see them when they're going from their building to the car and back up to the building because they're in a wheelchair and they're never downstairs. Or at the kopitiam, there are people who are sitting there by themselves, or maybe a group of people. So the challenge is to buy one person a cup of coffee, one older person, between now and February, and start to ask them questions and start to ask them about their lives. And we can give you as much information as we can, but talking to someone and having a cup of coffee with them, you're going to get more insights than you would from any articles that you read or anything else. And maybe if you buy one person a cup of coffee, then maybe the next weekend you buy another person a cup of coffee. But yeah, that's the challenge between now and then.
Okay, so I've been on both sides. I've been on where you're sitting as well, right? So I think when I saw the theme of this robot or this hackathon here, I was really, really encouraged because we're looking at social robotics for elderly, right? So that gives you a lot more latitude in terms of what we can do and how you can work with us. It's not clinical robotics for elderly. That's a whole different use case. Social robotics for elderly does imply then that there are social issues. Identify those social issues, which is exactly what the other panelists have said. What is that social problem that you're trying to address for that elderly at what stage of their lives, right? So it could be a social isolation issue. If there's someone who has maybe a diabetic amputee, right, and is now ashamed or afraid to go outside, afraid that people will laugh, or finds that his or her mobility challenges poses issues when shopping, cooking, or looking after their spouses, this is where your social challenge is a whole different ballpark, right? Having that robot, having that device there help you, how can you help them, encourage them, or even in other cases, help them accept their condition. I think Edmund was saying, right? Help them accept that this is where they are at. Don't try and change too much of this, but give them the encouragement that they need to move on with their lives. Now, I think some of you might have actually seen, this is a word of caution, some of you might have seen that article not too long ago where there was a Japanese couple, I think, that had this robot that they were bringing everywhere, that they loved that robot so much they were putting it in their shopping cart and then pushing that robot everywhere they went with them. Don't be the cause of that problem, okay? Don't cause a social issue for us, right? Help us solve a social issue, but don't take it to the extreme where now your robot becomes a proxy for a kid or something. All right, so I think that's the only 2 key points I wanted to highlight on this.
Other questions? Okay, I have another question. So as we're talking about social robots, in the places where you work, what do you see as the main social challenges for older people? So I'm going to ask each of you this.
Okay. The question here would be, again, sorry.
So what are the largest social challenges? Those could also be broken down into communication, to information. It could be interaction. There's a number of kind of subheadings underneath that. But
yep. So examining the user profile as well as our patient profile-wise, you find that in Singapore, at least, patients or the elderly are increasingly living at home alone for extended periods of time where their sons and daughters actually visit them on a weekly or monthly basis. So the amount of interaction that they receive from the outside world, from the community, can be quite limited. And that is where some level of assistive technology that encourages social behaviors can be really looked into. Yep.
The world has changed very fast in a way. So what has happened is that increasingly even those simple functions which they are used to becomes different. Even simple things like going down to the supermarket versus ordering online on Honestbee or Redmart. It is, again, they are fine if they can talk to someone who can do the online, but not them doing it themselves. But interestingly, when this was kind of surveyed across to the elderly, it's not something that they want. They want to be able to go down to the store and pick up the groceries themselves. Why? Because that is a social interaction that they are familiar with, which they grew up on. So we keep going back to what exactly is, what are people accustomed with? So the social issue we have right now is that we actually have 3 different generations of mindsets and 3 different generations of technology all in one living space. And that's going to be the norm going forward, probably more. But this is new for us in this millennium. Okay, in the past, you have 1 generation of technology for all, whether you're a kid or an elderly or an active individual. But today is 3 different sets. So as such, you will find that what some of the main social issues that our elderly is having is really trying to keep pace with, what's happening, how do I even connect with my family? I want to know what they're doing on a daily basis, but they can't tell me on a daily basis. It's not in their life. Why is it that I can't connect with my grandchildren the way that I used to connect with my grandmother? They are not interested to come 1 week before Chinese New Year to help me to bake cookies, which I used to do when I was young with my grandmother. So the generations have completely changed. 3 generations worth of culture, mindsets, and technology. Now, putting this at the back, when you're asking about social issues, again, in healthcare, we classify them separately. Those that are considered medical social issues, and in those cases would be how would we help to support people who are completely isolated because of their illness. right? Because they can't get to the right drugs, they can't get to the right care, they don't have the right information, they don't know what's going on with their disease. So that's medical. Then there is the social component, and in terms of trying to bridge 3 different generations of mindsets. Ultimately, in Asia, the focus of social is still the family network. And that family network, it's changing, and a lot of times it is something that is isolating our elderly. They don't understand why the next generation can't spend more time like they used to with their parents. So how then do we transform this with social robotics? Is it something where they can easily, when they need to connect with their families, we connect with our friends through Facebook. How could we use that kind of power to help what they need to do, but in the way that they can understand, not something that, even I don't use Facebook, sorry, I have to say that, because I can't keep track with 300 posts a day. But my colleagues, my younger colleagues, have no problem keeping track 300 posts a day. So how does that work? You have to understand that it's 3 different mindsets and 3 different sets of customization that we need to do.
I think for us, again, I think the most basic thing is to solve the problem that they want to face day to day. That is the key thing. So we actually turn upon assistive technology more than robotic technology. Assistive technology is very simple. For example, even with those with cerebral palsy, their hands are this way, and even to feed themselves is so difficult. They have the spoon now made in such a way that it will help them to feed, and that is what exactly they want. Something that they can do. They don't want sophisticated things. You can build better than that. But what I'm saying is the first line of approach to help these people is to provide them with assistive technology. For example, the visually impaired, they want a big magnifying glass or the screen that shows, big. And that's all they ask. They don't want a biotic eye. They don't request for a biotic eye. Hearing impaired, the same. They are all of them wants to first solve the basic requirement for daily living. I think that is more important so that they can live independently, at least. Happy or not, we don't know, but I think they will be happy if they can feed their own, do the home washing, cleaning up, and I think that is more important. Then if we want to do robotic things, you can actually add on to how to enhance the assistive technology that is available today to better their use. I think that would be a better angle.
Okay, so I think adding on to what our panelists have said, I think that's a really key thing, right? From a technology perspective, the key, I think, issue that you have to bear in mind is what I've said earlier. Know the cohort that you are planning your intervention for, right? And over and above all, maintain the dignity. Do not assume that everybody needs help to the extreme that you have to do everything for them, because that undermines fundamentally the dignity and their interest in helping themselves. Give them enough tools that they are able to achieve what you're after in the intervention that the outcomes are really key to what you're trying to drive at, right? So going to a very simple example, what's the right answer to track, for example, a dementia patient? Do we microchip them? That will certainly do that will solve everything. But it goes over and above the regulatory issues as a whole issue of the dignity process, right? Can you then use a robot in a way that provides proxy values for us? A robot that follows this person around, for example, and that robot becomes a proxy to tell us different things, where the person's at, where the person's located, how we can find them, how the family members can talk to them. Or even in the case where you have a robot that is now starting to see that this person is starting to take longer and longer in his walks. Don't forget, we continue to age, right? Whatever you plan for now may not be the same person in 1 year's time. Has your little robot been following this person and noticing that his intervals are taking longer to get from point A to point B? Is it time to bring them in for clinical assessment, something that Selina's side would be very good at, helping them to check for fall risk assessment. Maybe their eyesight's impaired, or even their hearing is impaired. As you talk to the robot, as you converse, you're starting to notice that some of the sentences are no longer making sense that they used to previously, right? So is that something that you start to take advantage of the proxy sensors and the multiple sensors that's available in this fantastic robot here, right? But do it in a way that's non-intrusive. Don't make your elderly sit for a eye test, hearing test, language test, or speech test, right? But you have all the tools available to you now. Learn to draw on proxy data and make inferences from that. That is the power of your AI that you have available in the CPUs today.
The two big buckets to me are what they have mentioned, assistive technology, assistive problems, and generational communication gaps. These are basically the two big problems. They have mentioned at length what they are, so I think we can look for solutions within these two big buckets, or even more buckets if you find them.
Dr. Sarma, do you have anything to add?
Just a few thoughts. So, as an internal medicine physician, I practice sort of across a spectrum of environments, from the ICU to a primary care practice. And obviously, the social needs are slightly different across different settings. So I'll start with the most acute. And when someone's acutely ill, particularly if they're elderly, they're at very high risk for delirium, which is to say, they become disoriented, they don't know where they are, they may even forget who they are if they're truly sick. And while there are pharmacologic interventions, actually one of the better interventions we have is to frequently reorient someone, to tell them where they are, to put familiar things around them, to provide them familiar cues that help orient them. And that's actually really important, because if they are confused and they're frightened, then it's very difficult to get them to engage with their care. So if you had a means of providing familiar cues, of engaging someone without keeping a person at the bedside around the clock, that might be a helpful sort of intervention that you could introduce. In sort of the less acute hospital setting, it's the social isolation, I think, in general is a problem for our patients, right? You come in, the doctor may see you 15, 20 minutes a few times a day. You'll see your nurse a few times a day, but if you don't have your family around, you're going to be a little bit more isolated. It can be frustrating. It can be confusing if you're given a new diagnosis to really understand what that diagnosis is, and having a way to engage your new diagnosis, and because ultimately you'll have to manage many of the conditions that we diagnose in the hospital as an outpatient. And ultimately for us also, then when we're planning on sending someone out into the world, when I will only see them in the clinic, maybe every month or two, if someone doesn't have good social supports, that actually then becomes a barrier to discharging them from the hospital. Because if I don't have a safe plan for making sure that you can take a life-saving medication, then I don't know if it's safe to send you out until I've figured out a way to do it. And one way we do it is we have visiting nurses, or we speak with families and we try to sort this out. But it's a very big part of what we do when we're thinking about someone's sort of disposition from the hospital. How do we get them out of our care and back to the lives that they want to lead? So I think there are opportunities for providing those sorts of supports sort of across the spectrum of care, but you have to do it in a way that's non-intrusive. And I think somebody mentioned earlier, so the importance of maintaining someone's dignity. I'm taking care of a patient right now who's got a fairly severe, widespread cancer, and his family's trying to get him as many supportive services as he can get. But for him, it's very important that he maintain his independence as long as he possibly can. It really just emphasizes how important it is to remember that we don't lose sight of the big picture of the patient's well-being and happiness and identity in our goal of sort of addressing individual measurable outcomes, such as saying preventing falls or making sure they take their medication 3 times a day, which are easier to measure but may actually impede their overall goal of wellness.
I'd just like to make one last comment from the provider point of view that might buy some of these innovation products. So we are looking out as a healthcare provider for a couple of things. So maybe I'll just leave that as kind of last thought, because usually we don't try to bring the business model so fast, but you might want to think about it. It needs to, A, increase the quality of the care that we are currently giving to our patients, or make it easier for the staff to work, providing the same quality but less healthcare resources required, i.e. less manpower. So either better quality of care or improvement in productivity for our healthcare professionals. Okay, so that's one point. From the patient's point of view, it needs to allow them to gain their healthcare goals, be it rehabilitative, assistance in daily living, at an affordable price. What insurance and they can pay. So those will be the 2 key things that we will look out for if we want to buy anything.
And we're wrapping up the panel here right now, and just 2 additional thoughts that I have as well is when you're thinking of ideas that you want to pursue, is also making sure, we can look at both one-to-one, as in one robot to one person or one robot to one family, but also in other environments, one-to-many. So how can one robot serve the needs of an entire ward at a nursing home or an entire HDB block, whatever the case may be. And then also what you had brought up earlier about assistive devices, this is another thing that we learned through one of our programs, is to really think about packaging as well. So how can whatever solution that you're creating be packaged with other existing solutions as well? And then really you're selling the package, not just the one solution. So another dynamic to think about. Any last questions before we wrap up? Okay, yes.
Yeah, I have a question for the panel. The one thing that I've learned from the hackathon last year and from listening to you is the problem of social isolationism and loneliness that the elderly feel. The 3-generation caregiving system doesn't seem to work anymore. So I would like each of the panelists to really quickly, just in your wildest imagination, what pain points would you like to see a social robot try to handle?
That's a difficult question, because if I can answer that, I'll be participating.
I think one of the key things is to use the robot in a way that it facilitates, it bridges, right, the links between the elderly and their community and their family, their patients, other members, whether irrespective. Nowadays, we have a lot of issues of nucleated families. Families are here, children are overseas, working, studying, and so on, right? The robot should act as a proxy, not necessarily a replacement, right? Proxy, facilitate, encourage, motivate. Key points.
Difficult question, because we don't use robotics so much. But I think robotics may be very helpful if we can collect data. I think it's useful information, because information is lacking and very fluid. So exactly we can't draw any conclusion. So robots can help, if possible, do some repetitive work to cut down manpower in the face of getting professional people to do work is getting harder and harder.
The pain point, we wouldn't say there are many pain points, but a couple that comes to mind in your question would be, how could we, A, use assistive technology and robotics to augment the work that the community is currently doing for our group of people that we're taking care of? So that's the first question. And I love the suggestion about having a coffee. Because if we need to spend more and more community nurses and therapists out there, that's just not going to be a sustainable model at all. So what could assistive technology or service robotics do to augment or even replace what is required for community care out there right now? Okay, so that's one. Two, how can we, who is so used to using information, be able to get that information to every single person when they need it? Now, I think from healthcare point of view, it is actually quite scary if you're ill or not even ill to try and navigate the healthcare space. And if you do not have the social support on top of it, like, you know, a son or a daughter that does everything for you, and so you just get transported to the doctor and transported back, and then just, you know, and all the medications get sorted out by you, by your family. In the absence of that, what's there? Even for us who have to take care of our own parents, it is quite, you wonder all the time, right? Am I doing the right thing? Am I going to see the right doctor? Is this the right set of medications? Are these the things that I ought to do? So the key point, pain point we want to solve when we talk to our patients and caregivers is peace of mind. Is there peace of mind for the children who's working hard at work, for their elderly who's at home? Do they know, or what is it that they need to know so that they do carry on with their life without having to worry all the time? Is mom coping okay? Is dad coping okay? Is grandpa okay? So on and so forth. And it goes both ways. The parents and the grandparents feel like they're burdening their children because they know that the world has changed. And they feel bad to us. They feel bad to burden. So the whole mindsets in terms of the social pain point, in terms of trying to get the right information to the families and to the person that we are trying to help, so to speak, that's quite, those are the key pain points to us.
Okay, so when we look at a dream product, I think I want to split it down into two main stakeholders here. Number one is the end user. So for the end user, what is a dream robotic product? It would potentially be something that is not even existent in their conscious mind. Like, it just is part of their life, which automatically allows them to continue with their way of living as they have been when they were healthy, interacting with their grandkids, their sons and daughters in a manner that is a very much a community spirit, if you may call it. Like, they can go down to the coffee shop and speak to people, interact with them, live their lives as they want it to be. So that's for the end user, a very non-obtrusive robotic device that simply just assists them in their daily living. Okay, so that's for the end user. For the caregiver side, it is really about extracting the right information, interpreting the right information, and presenting the right information at the right time that would really help them in knowing the condition of their loved ones and seeking the best help available out there.
And Dr. Sarma?
Yeah, so I think I have little to add. Just a few thoughts. One is that I think this idea of aging in place is really important. So, trying to keep people in their communities as long as possible really preserves their dignity and their well-being and their happiness. And I think this idea of unobtrusive technology and technology that just works. I mean, you will not believe how much time it took to set up this call, even though Skype is a really well-established technology. We spent about 20 minutes on the back end, and that sort of frustration for a sort of day-to-day technology for my patients is not a practical thing. It's not going to get taken up all that well. So, it's better to have something that does a few things and does them really well than to try to build a Swiss Army knife that is just too complicated and then ends up frustrating both caregivers and the patients themselves. So I think simplicity really should be a priority, and sort of ease of use, and just try to meet people where they are.
Okay, thank you. Thank you, everyone, for your input and your comments today. And I think we all appreciate being able to have you all here. So thank you.